Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today, our topic of discussion is about cytomegalovirus uveitis, and our guest speaker is Dr. Abdus Salam Diab. Dr. Abdus Salam Diab is currently working in King Saud University as a consultant medical retina and uveitis. Our second participant is Dr. Maria. Dr. Maria is working in San Rafael Eye Institute in Milano, Italy, and she has a special interest in ocular immunology. I am thankful to both of my participants today for giving us time for our audience, and I hope today's presentation will be very much beneficial. So, Dr. Abdul Salam, please.
Okay. Okay, thank you very much, Dr. Alim, for this kind invitation, and thank you, Dr. Maria, for accepting to be a moderator. Bismillah ar-Rahman ar-Rahim. Today I will talk quickly about cytomegalovirus anterior uveitis. And actually, I choose this topic because it is relatively a new uveitic entity. It was before diagnosed with different clinical diagnoses, as we will see through the presentation. As an introduction, as we know, cytomegalovirus is an important cause of opportunistic infection in the immunocompromised, manifesting usually as cytomegalovirus necrotizing retinitis. However, in recent years, it has been linked to hypertensive anterior uveitis in immunocompetent individuals. Regarding the clinical presentation of cytomegalovirus anterior uveitis, it has different clinical presentation, among which these of course these different presentation differ between geographical areas. In our community, the most common clinical picture is what was known before as Posner-Schlossman syndrome. And this presentation is usually characterized by recurrent attacks of unilateral mild anterior uveitis that is associated with very high intraocular pressure and some few or even single molten fat keratic precipitates. Usually in this presentation, we can see some corneal edema, endotheliitis, or iris atrophy, but typically posterior synechiae and vitreous or posterior segment involvement are typically absent. The second most common presentation is the Fox uveitis syndrome-like presentation. And in this presentation, we can see a clinical picture that is or that look like the typical rubella Fox uveitis syndrome with diffuse stellate shape, medium-sized keratic precipitates with some mild anterior chamber reaction and high intraocular pressure. Although the pressure in this clinical picture is less than the Posner-Schlossman-like presentation. And in this picture, we can see the pathognomonic nodular endothelial lesion, and that's called coin-shaped keratic precipitates. It is written in the literature that this type of keratic precipitate is pathognomonic for cytomegalovirus anterior uveitis. Compared to the Posner-Schlossman variant, this picture is associated more with cataract and glaucoma. But compared to the typical rubella Fox uveitis syndrome, it is associated with less cataract and vitreous involvement. The other clinical presentation is the mixed type, and this is actually is not common in our community. It is seen and mentioned that to be more common in the Western population. And in this type, we can see features of both Bosner-Schlossman syndrome and Fox-Uveitis syndrome. And this presentation can take acute or chronic recurrent course. It is usually associated or characterized by pigmented keratic precipitates that typically locates in the inferior cornea, and it can be associated with sectoral iris atrophy. Other clinical presentation is the endotheliitis, and this can come as an isolated finding or associated with any of the previous clinical pictures. And endotheliitis usually associated with some motum fat keratic precipitates with adjacent stromal edema and disseminate folds. And it can be focal or diffuse, sometimes resembling bullous keratopathy, and it can be associated with normal or high intraocular pressure. Regarding the diagnosis, actually in our practice, it is mainly clinical, but in the literature, the definitive diagnosis actually is by identifying and isolating the virus in ocular tissue. But these diagnostic tests usually associated with some false positive and false negative results that limit their accuracy and validity in confirming the diagnosis. Of these tests, the most frequently used tests are polymerase chain reaction to detect the virus DNA in aqueous humor, and the Goldman-Whitmer coefficient analysis to detect the intraocular antibodies against the virus. But as we said before, these tests, although the positive result can confirm the diagnosis, but the negative result cannot rule out the possibility of cytomegalovirus anterior uveitis. And also the test actually is not well available in many centers, and some laboratories and many laboratories, they are not well trained for these tests. So in our center, actually, we depend on certain clinical criteria to diagnose the cytomegalovirus anterior uveitis. And this clinical diagnostic criteria consists of the typical presentation of recurrent episodes of unilateral hypertensive anterior uveitis that's characterized by acute elevation of intraocular pressure, few medium-sized or motum fat keratic precipitates, and mild anterior chamber reaction. Usually, posterior synechiae and vitreous involvement are typically absent. And as we said, the intraocular pressure is typically very high. Sometimes there is iris atrophy and corneal endotheliitis. Usually, the corneal sensation is intact, and that's an important differentiating test to differentiate this the other herpetic keratouveitis. And of course, we rule out other causes of hypertensive anterior uveitis, especially those related to herpes simplex or herpes zoster or rubella, depending on the typical clinical characteristics of these uveitic entities. And all this clinical criteria is confirmed by the clinical response to treatment with anti-cytomegalovirus medications. We depend actually on the clinical diagnosis. Regarding the treatment, usually anti-cytomegalovirus medications are needed to control the inflammation and control intraocular pressure, and also to prevent or decrease the rate of relapses, and to prevent or decrease sight-threatening complications. And many literatures showed that early antiviral treatment lowers the risk of sight-threatening complications, mainly glaucoma, endothelial dysfunction, and permanent corneal damage. Also, some studies showed that the requirement for surgery was lower in patients whose antiviral treatment was initiated early compared to patients who received delayed antiviral therapy. And regarding the medication used, actually there is no consensus about the best drug or the optimal dose or duration or route of administration. But generally, valganciclovir and ganciclovir are the two main medications used. And they are used either with topical application or systemic route or intravitreal or combined use of these medications. And also recurrences and relapses are reported upon discontinuation or tapering of the medications. Regarding the duration of treatment, also there is controversy in the literature. Some suggest short-term treatment between weeks to 6 months, while other studies advocate longer duration of treatment, and they showed that longer duration is effective and safe to control the inflammation. Also, some studies suggest to keep patients, especially those with frequent recurrences, to keep them on prophylactic antiviral treatment for longer duration, whether oral valganciclovir or topical or even intravitreal ganciclovir. This is generally speaking. I will show you just some cases and to show you the different clinical presentation of patients we saw in our clinic. These are some patients who presented with the picture of Posner-Schlussmann-like. As we can see, some associated with few motton fat keratic precipitates, or even single motton fat keratic precipitates with some eyes quiet or very mild inflammation, and intraocular pressure is characteristically very high. Others, they present more with a picture that look like Fox uveitis with the diffuse medium-sized keratic precipitates, diffuse iris atrophy, and intraocular pressure is high but less than the Posner-Schlussmann variant. Some they present with the mixed type, but it is not common in our community, with these pigmented keratic precipitate with focal or cerebral iris atrophy, and some they present with corneal involvement with corneal endotheliitis, disseminate folds, and also keratic precipitates. And this picture actually is for the same patient after he received the treatment. Regarding the iris atrophy, it can be focal as this first picture, or it can be diffuse or patchy. We can see some patches with the atrophic stroma. So this is just a short or brief review about cytomegalovirus anterior uveitis. And in conclusion, cytomegalovirus anterior uveitis should be considered in the differential diagnosis of hypertensive anterior uveitis. In our practice, because of the limitations of diagnostic tests, clinical diagnosis may be more reliable for accurate diagnosis. And actually, there is a need to establish standard clinical criteria that is agreed upon. And this will be helpful for early diagnosis. Usually prompt treatment with antiviral, especially in our practice, oral valganciclovir, is effective and safe to control intraocular pressure and inflammation and to prevent complications. And also in our practice, long-term treatment course seems to be necessary for better control of the disease. And thank you very much.
Thank you, Dr. Abdul Salam. It was very informative and you really explained it very well. Now I will request our second participant, Dr. Maria, who has a special interest in ocular immunology. Please add his comments.
Thank you. Thank you very much for the invitation and for asking me to comment on this very nice and very interesting presentation. So first, I want to highlight that our CMV associated anterior uveitis is similar in Italy in terms of demographic and clinical presentation. We usually have to deal with young male unilateral hypertensive uveitis, and it is a both diagnostic and therapeutic challenge to treat this patient because first we have to decide if to make our diagnosis based on the clinical presentation or going for PCR anterior a PCR examination of the anterior chamber fluids. And second, we don't know properly how to treat this patient and how to prevent complication, for example, glaucoma. So first of all, do you do any PCR anterior segment exam, or what is the rate of your more invasive examination?
Actually, Doctora, at the beginning we started to do a tab and send it to for examination PCR. Many times the lab always reply that inadequate sample and the results are inconclusive. Okay, so our obstacle was the lab experience. So with time, we just depend on we try to establish certain clinical criteria that we follow to diagnose this. And actually, we did a study and we compared the cases that we treat. We found that most of them, or if not all, they respond very well to treatment with the anti-cytomegalovirus treatment. So honestly, now we just depend on the clinical criteria. I don't know about your experience.
I agree with you because sometimes we ask the lab for examination for herpes virus, EBV, and cytomegalovirus, and the material that we send to the lab is often not enough to test for all these entities. So it's very difficult to have the molecular confirmation. And sometimes we also have a double positivity for herpes virus and cytomegalovirus, and we don't know which one we have to trust in order to treat the patient appropriately. The second comment that I may do is that sometimes we have to deal with the very aggressive and progressive glaucoma in these patients. So we cannot manage this patient with drops, but we have to go for glaucoma surgery. Do you have experience with this aggressive hypertension?
Yes. Yes, we have. We encountered some cases like this, and this, I think, one of the causes that encourages us to start immediately anti-cytomegalovirus treatment, depending on the clinical presentation, because most of those patients who develop aggressive and severe complications are those who were treated with just topical medications. Many of them, they came to us with advanced glaucomatous damage with many complications, and they were treated elsewhere for years, just with topical steroids and some anti-glaucoma drugs. So they come very late, and we start them on oral, but unfortunately, many of them, they needed surgery, anti-glaucoma surgery. That's why from the beginning, when we suspect cytomegalovirus anterior uveitis, we immediately start patient on anti-cytomegalovirus treatment. And it is proven in the literature that early treatment with anti-cytomegalovirus can prevent the progression to sight-threatening complications.
I totally agree with you. Sometimes, I mean, if I have to leave a message, if you have a young patient with unilateral hypertensive anterior uveitis, do not think it is idiopathic, but have a very high suspicion it can be viral and cytomegalovirus related. So early diagnosis, if you have PCR, please go to PCR before doing the diagnosis of idiopathic, because it can be virus related and it needs treatment. For a certain period, we tried the topical drops with valganciclovir. It was made by our pharmacy in the hospital, but it was very difficult to maintain good compliance. So we also shift to oral valganciclovir to treat our patient. But I would say that at least 1/4 of them, at the end, they go for anything more invasive from the glaucoma point of view.
Okay.
Well, Dr. Abdul Salam, you have been using this valganciclovir, and what is we also use it. Digital profiles are done, everything, but using it for such a long time, what is the safety profile? Do you feel have encountered any complications in the management with this medicine, valganciclovir? And secondly, once the treatment is successful and the disease has subsided, if there is a recurrence, how do you manage the recurrence?
Yeah. Okay. Thank you very much. Actually, yes. Regarding the valganciclovir, one of the main issue is the possible systemic toxicity. But actually, we did a study about more than 40 patients who were treated with oral valganciclovir for a period over 1 year, each patient. None of them except one developed drug-related complications. So it is quite safe, and but of course we should continue following these patients and referring them to internal medicine for regular workup for any possible complication. But for all patients who were treated, just one patient developed pancytopenia that was reversible upon cessation of the medication. So it is quite a safe medication, but you should, as I said, you should follow this patient with regular workup. Regarding the second question, actually, it is an important question, because we faced it many times, that upon cessation of treatment or tapering the medication to a certain dose, some of them they recur. Okay, so those who have recurrence, we resume the same policy. We start them with full anti-cytomegalovirus dose. And then we keep them on the higher dose, or the dose at which the patient did not develop recurrences. And many of them, we kept them on prophylactic dose for long duration. Yeah, some of them for more than 5 years following with us, receive like every 3 days, just one tablet of valganciclovir, or every other day. Which is quite safe, and it keeps the eye under control.
Thank you, Dr. Abdul Salam, for your time. And I also want to thank Dr. Maria for giving us time. I am looking forward to you for further presentations in future also. Thank you.
Okay,
Thank you so much.
Thank you very much.
And